Okay, we are now recording our second 120 anatomy Zoom session. And what we're going to cover and look at today is the outer ear. Basically, the outer ear, the ear canal, and the eardrum. And I'll share screen here and pull up the old PowerPoint and notes to go along with it. Oh boy, yeah, okay, let's find those. Right here. Okay, here would be the outer ear anatomy physiology. There's your readings for it and stuff like that. And we're going to cover the outer ear and the ear canal, external auditory meatus, EAM, they call that. Scrolling down, we'll talk about the eardrum itself and landmarks to see on it. We won't worry that much about outer ear embryology. We won't be too concerned about that. But this is kind of how we will finish when we talk today on the physiology of the ear, of the outer ear. And the reason we're doing that, okay, and there's disorders. Yeah, okay, I just wanted to see the scope here. This is kind of interesting in the fact that we are covering this section right here, physiology of the outer ear. It kind of deals with what we were going to look at in acoustics, actually, at the very end of acoustics that I said we would kind of look at next week. Well, this is going to be looking ahead at some of that because all these things are related. Anyway, I'll start at the very beginning, and I'll pull up the PowerPoint to go along with it. This would be yon picture of the outer ear, sliced, looking at that.
Okay, I have a question.
Yes.
I guess whenever I printed off the notes, I didn't see the ones for that. All I have is just the overview. Oh,
the outer ear notes should be there. It's on Canvas.
It was on Rebecca's page, and I didn't have that.
Well,
I have the PowerPoint.
Yeah, you got the PowerPoint? Okay, well, yeah. I'll tell you what. Take good notes, and then I'll see after this Zoom session. I'll check and see. They should be uploaded. It should be all there, but I will take a look-see myself on Canvas. Actually, if I go, I could even try this now, as a matter of fact, just for fun, while we're here.
Okay,
we're good. Okay, I'm going to go into the Missouri school here. Colleges, and I'll see if I can see where it should be in the my OTC. Click here to log in and go to Canvas. You can see a dashboard. Here's 120 anatomy. I'll click on that. And I'll go into coursework, and then I'll go into unit 1. I think, no, that would be unit 2. That's going to be, I think, unit.
Oh, maybe that's why.
That's the peripheral auditory system. We don't want that. So I would probably go back here, and I would look more in unit 2. And when you look in unit 2, okay, I'll just blow this up. Lecture, the outer ear.
Okay.
Okay, and it should be, yeah, here, notes, outer ear and anatomy.
Okay.
Well, okay.
I can just print them as we go then.
Yeah, no worries, all good. Okay. And a lot of this stuff, since we'll be talking about it, you'll be able to readily see where it is in your notes afterwards, so no big deal. Okay. Auricle or pinna. When you talk about the auricle, A-U-R-I-C-L-E, or pinna, that is this outer ear. So the floppy part you can move. Now, if you grab your outer ear and wiggle it, okay, it's a lot like the nose, as I might have said last week. The skin at the end of your nose covers cartilage. The top of your nose, the skin covers bone. And that's the same in your outer ear. This is all cartilage here, so the skin is covering cartilage. But if you go in the inner half of your ear canal, the skin covers bone. Okay, and that's very important for us as HISs to know and to appreciate, because this is the part we're going to be dealing the most in fitting hearing aids anyway. So we have to know that quite well. If we go to the next slide here, you'll see an ear. And you don't have to know all of these pieces. This would be ridiculous. I'm going to tell you what you should know in here and what you don't need to know. The helix you should know. That's that outer ring. If you're looking at the helix here, it will be this outer area, helix. The antihelix is the next bump in. Okay, so if we go to the previous slide, this would be your antihelix. The Concha Bowl, C-O-N-C-H-A, Concha Bowl is the bowl inside the ear. If you go to the next slide, Concha Bowl. The tragus is the little bump that is right beside the bowl. It's the part, if you're facing, I'll see if I go to the previous slide, if it shows it. Tragus is not seen on this slide at all. If I stop sharing, the tragus is this little bump right here. Now the tragus, really when you're plugging your ears, the best way to plug your ears is not to put your fingers inside your ear. The best way to plug your ears when you don't want to hear something is to push on the tragus really hard. And that's the best way to block anything out that way. Just food for thought. But those are the four things I need you to know. Helix, antihelix, concha, and tragus. None of the other stuff is all that politically important. So I'm crura, I don't really care. Antitragus, I don't really care. All of this stuff, it's concha, tragus, antihelix, helix. Okay? So when you're looking at your notes, you'll see it exactly there. Tragus is an interesting word. It means goat's beard. Well, in men, hair grows from behind the tragus. Guess maybe that's why they call it a goat's beard. Who knows? Concha is the Greek word for shell. Anyway, the ear canal, external auditory canal, or meatus. Meatus is the Latin word for opening or channel. In adults, it's about 1 inch long, 2.5 centimeters in metric. Don't worry about the height and the width. I don't really care. It's mainly important to know the length. 1 inch, and basically, just to get a really good idea, a centimeter is about the width of a fingernail. So if you're looking at my finger right here, the width of the nail, that's about 1 centimeter. Put 2.5 of those together, and you got 1 inch. Of course, I could do this one too, but then again, I'd rather do that, okay? So basically, we're all good. All right, so the ear canal, it's important to know also has 2 bends in it, like a dog leg. It's not a straight canal. So when you're looking into an ear, it's very important to pull the ear up and back, because what that does is that straightens out the ear canal so that you can look in with an otoscope, okay? Because it has 2 bends in it. The outer ear canal is about 98.6 degrees. That's blood temperature. Bugs would love it, okay? One of the reasons you have earwax is because bugs don't like earwax. They hate it. The outer ear canal is surrounded by the mastoid portion of the temporal bone. The mastoid portion of the temporal bone. How do we say that in English? If you put your finger behind your ear, that's the mastoid bone, that bone that sits right behind the ear. The bone that surrounds all of the ear, the outer, middle, and inner ear, is called the temporal bone. And we've had that last week, the temporal bone, the whole side bone of the skull. And the temporal bone has 2 parts. The soft part, and you can look at last week's PowerPoint to see this, the temporal bone. But the temporal bone has 2 parts. A soft part, the mastoid, which is the bone behind your ear here, and the petrous. Petrous comes from the word Peter. And if you ever study your Bible or whatever, Peter, the rock, the apostle, Petrus is Greek for rock. Now, so the hard petrous portion of your temporal bone surrounds your inner ear, your cochlea. The mastoid, the soft, porous bone, that tends to cover the outer and middle ears. And it's very porous. If you can see how porous the bone is here, so it's got all holes in it. It's soft, very unlike the inner portion, which is the petrous portion of the temporal bone. Now, okay, the outer half of the ear canal skin covers cartilage. Now the cartilaginous portion is where the wax glands are. That's what produces wax. That's where hair grows in men's ears, you know, all of that stuff. Sebaceous glands create cerumen. Earwax is called cerumen. C-E-R-U-M-E-N. Sincere means without wax. I think I told you this last week. Okay, if you really loved someone in the Roman Empire times, you gave them a solid silver statue instead of one filled with wax. Cerumen means wax. The inner half of the ear canal, yeah, of course, sincere means without wax. The inner half of the ear canal, no glands or hair. So look at this. The inner half, where the skin covers bone, wax doesn't naturally get produced there. When you use a Q-tip, you end up pushing the wax there, but it doesn't naturally grow there, okay? The skin there is very, very smooth. Cerumen, earwax from secretion of blah, blah, blah. Who cares if you know the names of those? I really don't care. Okay, the skin of the external auditory meatus is very thin. It doesn't flake, as is typical with skin. It moves slowly like a glacier on the eardrum and moves and grows slowly onto the bony portion of the ear canal, the skin that covers the bone. And this skin gradually migrates to reach the border of the cartilaginous ear canal. The skin meets the hairs and cerumen, which stops its movement. Sometimes it forms wrinkled, dried, dead skin on the surface. This can break off into flakes, mixes with earwax, and this is what we are commonly seeing as dark earwax. Don't worry about this stuff. It's just a very sad, typical, kind of a gross story. Anyway, otoscopic examination of your ear canal. We can always call it the EAM, external auditory meatus. Pull the ear up and back to straighten out the canal. Kids have a differently shaped ear canal. It goes down instead of up. So during an otoscopic exam, you tend to pull a child's ear down and back, not up and back. But we are HISs to be, and we are not testing kids, and we are looking in adult ears. So from my perspective, it's most important to know pulling the ear up and back. Temporal mandibular joint. Let's see if I've got a picture of that. No, of course not. That would have to be in last week's PowerPoint. Great, Ted. Just great. Yeah, here you go. Last week's PowerPoint shows you temporal mandibular joint. I'll have to make sure to put that slide in this week's. Actually, I can pull it up here. That's not hard to do. All of this is all pretty easy since we can always do these things live. Okay, I'll just pull up a PowerPoint slide of the temporal mandibular joint. I know we had it in last week's thing. Okay, here it is. Okay, there's your jawbone. Here's your skull. Here's your temporal bone. The temporal mandibular joint is right here. It's a ligament that connects your jaw to your skull. And this can often get arthritis. TMJ, they call it, temporal mandibular joint syndrome. Often the pain is manifested in the ear. So many people go to an ear person with pain here when actually they should be seeing a dentist. Okay, but just so you know, TMJ is something that can cause a lot of pain, and it can produce otalgia, which is ear pain. Oto, ear, algia, pain. Okay, so arthritis of that joint causes TMJ syndrome. All right, enough on that. Let's look at a bit about the eardrum itself. The eardrum itself. So when you're looking, this is just giving you, this slide here is just showing you wax glands, blah, blah, blah. Just kind of gives you kind of a picture of ceruminous glands, wax formation. Cerumen waterproofs the skin and protects the external ear canal from exogenous agents such as insects. See, told you bugs don't like it. Here's an otoscope. One needs to be very careful looking into an ear with an otoscope because this is called the speculum. And if you push too hard into an ear with the speculum, you will pinch the skin here, right here. This skin is always movable. Everything moves with the outer ear. But once you get to here, that skin has nothing else but bone underneath. You stick a speculum in and you can pinch this part of the skin really easily, and it will bleed or it will swell like crazy. It always looks worse than it is, but it will freak out a client so bad, he or she will not come and see you again. So when you're looking, and you will learn this in your labs, when you're looking with an otoscope, you'll always use your pinky to brace against the cheek to make sure you're not pushing the otoscope in too far. The bracing techniques are something you will be learning in labs. When you look at an eardrum, now the eardrum is about the size of your finger when you point it, about the size of your finger. So if you point and look at the end of your finger, that's about the size of your eardrum. Okay, I always like to just give people basically a gist of what we're talking about here. Now, you can look at a right eardrum or a left eardrum, and there are landmarks on an eardrum. Okay, eardrums, you will see sort of a teardrop shaped thing here. That is the first bone of your middle ear. Lay people call it the hammer. We call it the malleus, M-A-L-L-E-U-S, the malleus. It's the first bone of the 3 bones of your middle ear. Your eardrum is kind of like a bathroom window, you know, the kind that lets light through but you can't see through. It's not transparent, it's translucent. Light can get through and you can see sort of shadows, a little bit of stuff. So this is called the Manubrium, M-A-U-B-R-I-U-M, Manubrium handle, the handle of the malleus bone. And that is literally stuck against the back of your eardrum. You'd have to tear it off the eardrum. It's not just that your eardrum touches it, and your eardrum is not a flat surface. It's like a cone of a speaker. It's very much like a cone of a speaker. At any rate, the bone doesn't touch the whole eardrum, it just touches the first half. If you're wondering what this top part here is, good. This is called your pars tensa, your tense part of your eardrum. This has 3 layers of skin, an outer, a middle, and an inner layer. The outer layer of skin is continuous with your ear canal. The inner layer of skin is continuous with the lining of your middle ear space. And the middle layer is tough as nails. It's called the arachnoid layer. It's like a spider web. It's got these spokes. And that's what makes your eardrum very, very stiff. Now I'm going to look to see here if I've got a drawing that will really show this well. And of course I don't, but again, it's very easy to fix. So I will just go over to here and pull up the middle ear PowerPoint from next unit so that you can see what I'm talking about here. You'll see it better from what I'm describing, okay? Here's a picture of what I'm describing. Here's your eardrum. This is your ear canal. Here's your eardrum, much like a speaker. Here's the malleus. And you can see it's the manubrium, the handle of the malleus, goes from the top of your eardrum to the middle. And that middle part is called the umbo, U-M-B-O, umbo. So that bone doesn't touch the whole back of your eardrum, it just touches the first half, but it's literally attached. This is the incus bone, and this is the stapes bone. Malleus, incus, and stapes. But that's next week. I'm just showing you this so you get an idea of what I'm talking about there. Okay, so we'll go back to the good old Unit 2, go up to here and up a little bit, ski, and back to this picture. So when you're looking at this manubrium of the malleus, here's the umbo. Manubrium, this divides the pars tensa, the tense part, from the pars flaccida, flaccid part. So this part is stiff, this part is not stiff. This part doesn't have that thin or that middle tough fibrous layer. It doesn't have it, okay? In other words, it just has the outer and the inner layers of skin, but not that tough middle layer. Why am I saying that? Because even as you go up a flight of stairs, the air pressure will change. And that pars flaccida accommodates different air pressures from outside the eardrum to behind the eardrum. You know, when you're going up a mountain or you're going way up high in a building and you got to kind of swallow to clear your ears, that's because the air pressure has changed around you, but the air pressure behind your eardrum is still at regular room air pressure. So you've got uneven air pressure. So you blow your nose or you swallow or you do what you can to straighten that out, okay? The pars flaccida accommodates tiny changes in air pressure, even from going up a flight of stairs, so that you don't feel the change in air pressure. It just kind of accommodates that. The pars tensa is the main part of your eardrum. If I blow this up now, you will see something here, right here. That is actually the incus bone. That is, and I'll show you from the other slide, that is actually this guy right here. It's this. You're seeing that through the eardrum. Isn't that wild? So, okay, so you're going back here. So this is the pars flaccida, the flaccid part. Pars tensa, the tense part. The umbo is the center. And I'll pull it closer to you. And this is what you call the cone of light. The cone of light isn't a real thing. It's just a reflection of light from your otoscope. And in the right ear, it should be at 5 o'clock. And in the left ear, it's at 7 o'clock. So when one shows a picture of an eardrum, you can tell which one it is by looking at the direction of the cone of light. In a healthy ear, you should be able to see a cone of light. All these landmarks should be visible in a healthy eardrum. If the eardrum is not healthy, you will have difficulty seeing these landmarks. This top T part here is called the nodes of Ranvier, R-A-N-V-I-E-R, nodes of Ranvier. And that's, of course, in your notes. That separates the pars flaccida from the pars tensa. Cool. All righty. What other lies can I tell you? Okay, here we go. So we scroll on down. Here's the parts we just talked about. Eardrum has 3 layers. Area of the eardrum, I don't care. I don't really care whatever. But look at this. It only needs to vibrate a billionth of a centimeter to give you an auditory, to let you to know you heard a sound. It only needs to move a billionth of the width of your fingernail. Good grief. I mean, just a billionth of a centimeter of movement of your drum is enough to tell you that you're hearing a sound. Wow. Umbo is the center. Okay. Manubrium of the malleus embedded into the second layer of the TM. TM means tympanic membrane or eardrum. You can also see the long process of the incus through the eardrum. I have an extra space here. Put an I there, Ted. Okay, and then there you go. Annulus. Annulus is the ring of tissue around the outside of the drum. Let's see if I've got a picture of that. Here's the annulus. Okay, the ring of tissue at the outside of the drum. Nodes of Ranvier, a Y-shaped division at the top of the eardrum that divides the pars tensa from the pars flaccida. Okay, these are the pieces and parts of the drum. Pars tensa, sometimes called shrapnel's membrane, it's the large surface. Okay. Pars flaccida, smaller, looser tissue, moves even with very small changes of air pressure. Cone of light we've discussed. Orientation of right and left eardrums. We talked about 5 o'clock and 7 o'clock. Now the eardrum is unique, and I'll just kind of say this. It is unique in that it has all 3 original embryonic layers of skin. Just after gestation, the embryonic disc from the union of a father's sperm and a mother's egg, when conception begins, you've got 3 layers: ectoderm, mesoderm, endoderm. And ectoderm eventually forms into nerves and skin. Mesoderm eventually forms into muscle, bone, and cartilage. And endoderm is the slimy stuff: your guts, your intestines, the insides of your cheeks, all this, and the inside of your middle ears, the inside of your nose, all the slimy stuff. So your outer and inner ears thus originate from ectoderm, because that's nerves and skin. The middle ear comes from mesoderm. Anyway, this is the sentence you need to know. The eardrum is unique in that it preserves all 3 original skin types. It's the only part of your body that does. Okay, now here's where we cut to the quick. Check this out. Now we're going to talk about where we were going to go in acoustics. Okay? Really wild. Your outer ear has the shape it does, as we said earlier in acoustics, so that it emphasizes the high frequencies of speech, the consonants. Now, it mainly functions, and always remember, anatomy is what it is, the form. Physiology is what it does, okay? Anatomy is the form, physiology is the function. That's why they always say anatomy, physiology. Anatomy is what it is, physiology is what it does. So when you look at the physiology of the outer ear, we've talked about the pieces and parts. Now, what does it do? What is its physiology? That's what we're talking about here. It mainly acts as a funnel to gather sound, but the resonance, there's that word. See why you need to know acoustics? The mass of the concha and the stiffness of the concha. The mass and stiffness of the concha resonate with 5,000 to 6,000 hertz. Very high frequencies. Kind of frequencies like the letter S. Very high pitched. Important for localizing the direction of high frequency sounds. But now, recall from acoustics, and I can't say recall because you haven't had it yet, so now I'm going to introduce you to it. So I'm going to kind of go over to here. I'll stop sharing for a second. Look at my cup. Now, I don't want to tip it over too much or my coffee will spill on my keyboard, okay? But a cup is a cylinder, okay? Just like this, like a pen. It's a cylinder that's closed on one end and open on the other end. All cylinders that are closed at one end, open on the other. Whoa, shit, I just spilled my coffee. No, hang on there, Ted, not bad. I'll grab a tissue. I didn't put it on the keys, thank God. Hang on, be right back. Get overly hyper when I'm trying to explain something. Let me take it. Be right back, hang on. Okay. Here we go.
I logged in at the perfect time there.
Yeah, perfect. You arrived at the height of insanity here. Okay, so yeah, gotta like wipes. Okay, quarter wave resonators. All objects that are cylinders closed at one end, open at the other end, all objects like that vibrate or resonate with sound waves that are 4 times their length. So if your ear canal is 1 inch long, guess what? It's a quarter wave resonator. Why? Because your ear canal is closed at one end and open at the other end. We'll share a screen, look at the PowerPoint here, and we'll check out the outer ear. There. It's a cylinder. It's closed at one end. It's open at the other end. It shares properties in common with a cup. All such objects resonate with sound waves 4 times their length. So if this is 1 inch long, it's gonna resonate with sound waves that are 4 inches long. That's why it's called a quarter wave resonator. Okay? Just a little tip, that's on quizzes and that's on exams. And that's where acoustics meets anatomy. Okay, this is why I like to have the two courses taught simultaneously, side by side. So read here, it's a quarter wave resonator, closed at one end, resonates best when it's a quarter the length of the sound wave, or when the sound wave with sound waves that are 4 times its length. The ear canal is basically 2.3 centimeters long in adults. Why don't we just say 2.5? Just keep it simple. It's going to resonate with sound waves that are 9.2 centimeters. Basically, if this is 2.5 centimeters, 4 times 2.5 is 10. If this is 1 inch, 4 times 1 is 4 inches. Okay, same thing, metric or imperial, who cares? But this is what I want to say then. Frequency is wavelength over, or the speed of sound over the frequency. Remember we studied that? Frequency is wavelength or the speed of sound over frequency. Wavelength is speed of sound over the, wavelength is speed of sound over the frequency. Frequency is wavelength over the, or speed of sound over the wavelength. So let's calculate it. What would it be? Wavelength is going to be, okay, so what would the frequency be of a sound that would naturally resonate with the ear canal? Well, let's figure that out. The ear canal is, I'll get my calculator here. The ear canal is 1 inch long. So sound, how fast does sound travel? 1130 feet per second. Okay, so if we say the sound waves, it's going to vibrate with sounds that are 4 inches long. So let's calculate this here, Ted. 1130 feet per second divided by, so the frequency over 1 is equal to the speed of sound over the wavelength. Okay, I'm thinking out loud here, bear with me. So the wave, if it's 430 feet per second, what is 4 inches compared to a foot? It's 1/3 of a foot, isn't it? Right? So 1/3 of a foot. 3 times 4 inches is 12 feet, is 12 inches. And 12 inches is a foot. So take 1130 and divide it by 0.3 feet, because you got to work with feet. You can't do apples and oranges. If I've got 1130 feet per second, my bottom of the fraction has to be in feet as well. I can't talk about inches. So 4 inches long is 1/3 of a foot. So 1130 feet per second is the speed of sound in air. Divide that by a sound wave that's 4 inches long, or 1/3 of a foot. 1130 divided by 0.3. Get the calculator out here. 1130 divided by 0.3. Oops, come on, Ted. Need a calculator that you can see on. Okay, 1130 divided by 0.3 equals 3,766. Well, you can't see it on there, but anyway, 3,766. Pretty darn close to 3,800. Told you. So guess what? That's a high frequency sound. That's the frequencies of consonants of speech. S, F, TH, K. So your ear canal, being a quarter wave resonator, is going to naturally vibrate with sound waves that are 4 times its length. And we wanted to figure out what the frequency is. Well, frequency is the speed of sound divided by wavelength. Wavelength is the speed of sound divided by frequency. Whatever way you want to work, it doesn't matter. But here we go. The ear canal is also made of skin and bone, not ceramic or glass. So because it's made of skin and bone and not out of ceramic or glass, we're going to have things fudged a little bit. And this is the picture you get. Now look at this picture closely. It shows you frequency and it shows you decibels of resonance. 125 hertz. If I had 50 decibels of sound, 125 hertz, and I was able to measure what's taking place at the eardrum, I'd have 50 decibels. If I had 50 decibels of 250 hertz, I'd measure in my ear 50 decibels of 250. If I had 500 hertz at 50 decibels from a speaker here, I'd measure in my ear 500 hertz at 50. If I took 1,000 hertz at 50 from a speaker here and measured in my ear canal, I'd have 1,000 hertz at 50. But if I had 2,000 hertz at 50 coming from a speaker, in my ear, I'd measure about 70. Because now it's beginning to resonate. Because your ear is made out of flesh and bone, that 37 or 3800 hertz is kind of spread out a bit. It's not a cup like a glass. It's made of flesh and bone. So here's the resonance. It's spread out from about 1500 hertz to just past 4000 hertz. So all of these frequencies from about 1500 hertz to 4000 hertz are all given about 20 decibels extra for free, just because of that resonating property. And that, my fine feathered friends, is the main reason we have our outer ears the way we do. Quarter wave resonators with their own mass and stiffness properties, but because it's like a cylinder, closed at one end, open at the other, it's going to resonate with sound waves that are 4 times its length. 1 inch long, it's going to resonate with sound waves 4 inches long. You want to find out what the frequency of that is? Divide the speed of sound, 1130 feet per second, by 3 inches, which is or 4 inches, which is a third of a foot. 1130 divided by 0.3 gives you about 3800 hertz. Slain and pimple. That must be understood on quizzes, midterms, and finals by all HIS students who graduate from OTC. It's this kind of knowledge, you guys, that separates you from people who don't take a 2-year degree. If you talk to people from who are working in the field, most of them will not be able to explain this. You will. Instead of being technicians who push buttons, you will be technologists who know why you're pushing the buttons. Okay? You will be able to flip out an audiologist by what you know. The audiologist with their AUD, Doctor of Audiology, they study this stuff. And if you come from OTC and are able to say, well, yeah, the outer ear canal is a quarter wave resonator, so it's naturally going to resonate with sounds 4 times the length of the ear canal. And when you would do the math, it'll end up in it with the high frequencies of around 3800 hertz. An audiologist will go, holy shit, how do you know that? Like, what? Good. In fact, if you can freak out an audiologist by what you know, then like an old salmon, I can swim up the stream to die. Because I'm an audiologist and I'm here to just cram it into you guys so you understand some of the theory, some of the good stuff, the juice of it. We're going to talk about the middle ear, of course, and all of that next week. But this was the main physiology of the outer ear. It's really important to have a good grasp on that. Now, I'm going to go to here and see if we can get out. Now let's talk about other stuff here. Okay, let's go on to look at some really weird looking eardrums and stuff. Okay, this is a picture, a really kind of a complicated picture of the resonance that I showed you. Here's the resonance of your Concha Bowl, 5 to 6,000. Here's the resonance of your ear canal alone, and here's the total, the sum total. Basically, this curve here is quite similar to this curve that I'm showing you here. This is just my view of it. This is the way they are showing you. But notice how that total T is around 20. Same with mine. Okay, similar. So this picture and this picture are related. This one speaks in English and this one speaks in Greek. Okay, but same story. Now, don't worry about that. Again, it's just showing you the total effect again. It's mostly close to 3000 hertz and all that stuff. Anyway, here's a picture of the letters of speech placed on what's called an audiogram. Now, have you ever all had any exposure to an audiogram? Yes or no? Okay, sort of, eh? Samuel has. Okay, an audiogram is where your hearing levels are placed on. These are the frequencies tested on an audiogram. Usually 250 hertz, which is like middle C, 500 hertz, 1,000, 2,000, 4,000, and 8. We usually test hearing sensitivity for the right ear and the left ear separately. These are decibels, 0 being very soft, 100 being really loud. And the right ear, we make zeros, O's, and the left ear we call X's. So we play tic-tac-toe. So we test the sensitivity of the right ear and the left ear separately. Now remember what I was talking to you about in acoustics earlier in our Zoom session? Put your hand to your throat and say the letter Z. Z, throat vibrates. Throat vibrates. J, M, D, B, A, O, A, R, all your vowels. But when you start getting they are higher in pitch and they are softer. See how the decibel levels of them is only like 20 and how this is around 40? So that's what this does. It helps you hear these pitches better because as they are naturally spoken, these are softer than these. Okay? That's why you've got this gift of this resonance due to the length of your ear canal as a quarter wave resonator. Okay, this sounds like a group you could go listen to tonight. Let's go to hear bone conduction and the occlusion effect. Anyway, let's talk about the occlusion effect. The occlusion effect is also something unique about the outer ear. Now the occlusion effect is this. I'll scroll down. Here's your notes. Oh, by the way, this is this black stuff here. What's the benefit of your outer ear, quarter wave resonator, all that stuff? This is exactly what I just said. Okay, so be sure to keep these notes and read them well. Occlusion effect. Now this is kind of cool. Have you ever listened to, have you ever listened to the sound of your own voice on a recording? Does it sound good to you? When you listen to, no, it doesn't, does it? It sounds kind of tinny, it sounds weird. I know my voice sounds like geese farts on a muggy day. I mean, my voice does. I pity you for having to listen to me. Anyway, when you hear a recording of your own voice, you are hearing yourself only through sound waves coming through the air. When you hear yourself talking, though, when you're talking, you hear yourself through sound waves that go out of your mouth into your ears, but you also hear yourself through vibration of the bone up to your ears. So you hear yourself speaking by air conduction and by bone conduction. So you sound deeper and richer and louder to yourself. When you hear yourself on a recording, you are hearing yourself as others hear you. Because when you talk, others hear you only through air conduction, not by bone conduction. So your voice on a recording, you're listening to that going, oh, that sounds awful. That doesn't sound like me. And everybody else goes, yeah, it does. It sounds exactly like you. You're the only one who doesn't think so. And that's because you hear yourself speaking through bone and through air. Others hear you only through air. When you're listening to a recording, you are here for the first time listening to yourself as others hear you. Now, weird, huh? Just thought I'd tell you that. Let's talk about the occlusion effect, which is kind of interesting. When you plug your ears, so now what I'm going to have you do is I'm going to have you plug one ear, and hum. 1, 2, 3. What ear did you hear yourself loudest in? You heard yourself loudest in the ear that was plugged, didn't you? 1, 2, 3. All right. Now do that same thing with the letter S. 1, 2, 3. It's not so pronounced, is it? Now do the letter M again. And then unplug. See how it gets louder when your ear is plugged? That's called the occlusion effect. Now, hearing aids would naturally plug up your ear. So people would always hear their own voices loud. That's why hearing aids always have a little hole in them called a vent. You will be learning about this next semester. And a vent in a hearing aid lets the loudness of your own voice escape to reduce that occlusion effect. If we look at our notes now, the occlusion effect, let's find out the real definition of it. Okay, lows of your own voice. Let me just highlight these three sentences. The low frequencies, low hertzes of your own voice resonate with the mass of your skull, because remember, mass resonates with lows, stiffness resonates with highs. We just covered this in acoustics a couple hours ago. And the mass of your skull, now that it's vibrating, in turn vibrates the cartilaginous portion of your ear canal. And plugging your ear prevents this added resonance from escaping. I'll read it again. The lows of your voice resonate with the bony mass of your skull, because your skull has mass and it's going to resonate with lows, which in turn is going to vibrate the cartilaginous portion of your ear, and plugging your ear prevents that added resonance from escaping. The occlusion effect only happens when you yourself are talking. This doesn't, plugging your ear is going to make your ear less sensitive to sound from the outside, but it's going to make you more sensitive to sound from you. So that's the source of a test called the Bing tuning fork test, and doctors do this. If they suspect you of having an ear pathology, they will take the tuning fork, and I'll stop sharing here, or they'll take the tuning fork and go dong, and then they will put the tuning fork behind your ear on that mastoid bone, and then they will plug your ear and unplug it. Plug your ear and unplug it, and they're going to ask you, when is it louder? And if you say it's louder when my ear's plugged, they'll go, good, that's normal. You should get the occlusion effect when your ear is plugged. Because a tuning fork on your bone is just like you yourself talking. It's coming through bone conduction. When you plug your ear, bone-conducted sounds are louder. When you plug your ear, your own voice by bone conduction gets louder. That's normal. You should have that. If you don't have that, Houston, you've got a problem. Okay, so doctors do that test. It's called the Bing tuning fork test, based on the occlusion effect. All right, let's go here. Let's look at some disorders of the ear. Now we get to have fun. Basically, there's only a few. The first one is called stenosis. Stenosis just means your ear is partly plugged. It's a narrowing of your ear canal. Now, what the Sam Hill is going to narrow your ear canal? Well, shoot, anything can narrow your ear canal. Try earwax, okay? Try having this here. Let's go to this picture here. Okay, this is looking into an ear, a good healthy ear. I'm going to blow this up a little bit. Actually, I'm going to start where we ought to start, right here. Oh yeah, oh God. Here's a hairy ear. Have a look at that guy. This is what you call, oh my God. Anyway, here's atresia. Some children are born with no ear canal. That's called atresia. Surgery can often, they can do plastic surgery on it and make a fake ear canal, sort of. Surgical reconstruction may be successful in the presence of a relatively normal middle ear behind it. So they can, but atresia is a total closure. When you're looking in at an eardrum, okay, I should have taken the word right off of here, because this is review. Here's the manubrium of the malleus. This is the umbo. Here's the incus bone behind it. Here's the cone of light. The normal right ear canal at 5 o'clock, cone of light. Here's another ear canal, or eardrum. Manubrium of the malleus. You can see kind of the incus bone behind, cone of light at 5 o'clock, Normal, healthy eardrum. Normal, healthy eardrum. A bit of blood vessels, capillaries, almost looks like a bat wing here. Strange. This is the outer half of an ear canal where wax and hairs grow, especially in men, hairy ears. This is the inner part of the ear canal. See how the skin is all smooth like a baby's behind, okay? So there's no wax here, no hairs here. Any wax found here is because you pushed it there with a Q-tip, all right? This is the migration of that wrinkly skin that naturally migrates out and gets wrinkly as it meets the hairs and wax of the outside, but nonetheless, whatever. Again, a close-up here, earwax as it's forming. Nothing wrong with earwax. It lubricates the ear canal, and also bugs don't like it. This is a good chunk of earwax here. How you liking this puppy? Okay? This is not going to cause any hearing loss because sound can still get through here. Only when wax totally blocks things. But look at how slimy that puppy is. I mean, that's, yeah, a little unpleasant, but that's grown in a whole lot of people's ears. Now, here's a great variation in the colors of earwax. And sorry, you guys, this is what you're going to be looking at. This is anatomy, and you got to know what pathology is of the outer ear. And this is the part you're going to be dealing with the most. This is yellow wax, which is newer. This is really black wax because this is mixed with a lot of debris, dead skin, dirt. So a great variation in the color. What's your favorite flavor? Chocolate, strawberry, or vanilla? All right. This is a kid who stuck a piece of jewelry or something stuck in his ear. This is also causing stenosis. Atresia, we said, is a total plugging of the ear. Stenosis is a partial plugging. So here's stenosis. Stenosis can be caused by wax, partial plugging up. Stenosis can be caused by something else stuck in your ear. Stenosis can also be caused by a bug in your ear, like a cockroach. Have a look at that. Okay, so all that stuff. I mean, bugs would love to get into an ear, so it can be just a little gross. So when you look in some ears of poor socioeconomic areas, but always remember the term stenosis means a partial plugging of the ear canal, and it can be caused by bugs to stuff stuck in an ear to wax naturally growing in an ear. That's stenosis. Look at this. This is an abrasion of an ear canal, either done by cleaning of the ear canal, jamming an otoscope too far in, and there's that skin of the covering the bone, which doesn't give. And we were mentioning looking in with an otoscope that you can pinch it. Okay. Here's a hematoma, which means like a blood blister. Really aggressive use of cotton tip applicator. Evidence of more severe trauma can be found. It always looks worse than it is, okay? But if you make a client's ear bleed, you're not going to have that client back. This is Otitis Externa. Oto, ear. Itis means inflammation. External means outside. Okay, so outer ear inflammation. So this is an inflamed ear canal, and you can see the skin is swollen, and you can barely see the eardrum. Okay, blah 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 blah. I don't care if you know what any of that is. You just need to know how to read Latin like that. Oto, ear. Itis, inflammation. External, outer ear infection. Cool. Look at this, bony exotoses. These are like bony tumors. Now this is called swimmer's ear. Women get this more than men. Women can tolerate swimming in colder water than men can. Women have an extra layer of fat underneath their skin. Men don't float as well as women do. So oftentimes long-distance swimmers in cold water, women usually can do it, guys can't. At any rate, people who swim a lot in cold water, the body naturally defends the eardrum from it by growing bony growths like this to help protect the eardrum from exposure to cold water. Sometimes it's called swimmer's ear. Here's an osteoma. This is a rare but benign tumor of the temporal bone, usually lying in the external ear canal. If they occur, they are more likely to warrant surgical removal because they can compromise the ear canal. That's a stenosis. It's not totally blocked. It's partially blocked. A doctor will go in and they will surgically take it out. No problem. Day surgery. This is going to be caused from a person who had middle ear infection. We'll cover this in following weeks. And he blew a hole in his eardrum. Okay? Sometimes these will grow back by themselves. Sometimes they're too big to grow back by themselves. A pinhole in an eardrum will grow back by itself. If the hole is much larger than that, they often take cigarette paper, get this, Vogue cigarette paper, and they'll lay a square of it over the hole. So the skin has like a scrim to grow over and fill. Here's a traumatic perforation of an eardrum. Sudden changes in air pressure or direct trauma to the eardrum from an inserted implement. In this case, it was a result of a blow to the side of a head. There's a big hole in the eardrum. Yikes. This is, now look at the name. Otitis, ear infection or ear inflammation, media, middle ear infection that we will be covering next week. Look at what it's doing to the eardrum. It's all the pus behind the eardrum is blowing it outward. And that is what's called an earache. That hurts. Here's another type of otitis media, oto-ear-itis inflammation media middle. As the condition progresses, the middle ear fills with pus, causing the drum to bulge laterally. So here's mucous otitis media. This is kind of called glue ear, but we won't talk that much about it. It's from constant ear infections that have had like a dull appearance of the eardrum, but nonetheless. Look at this, the mucoid fluid drawn by a doctor out from the middle ear. When you first get middle ear infection, the pus isn't white, it's clear. Much like under a blister. When you get a blister, you've got clear fluid. It hasn't turned infectious yet. This upper one here is infectious. This is not. But we'll cover that more next week. This is early otitis media, and you can see a bit of bulging of the eardrum. It's not quite as far along. Here's also fluid behind the eardrum. You can see the fluid there. So this is going to cause otitis media. This is often what's done for ear infections. They put a hole in the ear and they put a tube in to keep the hole open so that air can constantly communicate in there. And there's reasons why they do that. It's because the child's eustachian tubes going from the back of your throat to your ears are not functioning correctly. They're swollen shut. And so the middle ear gets ear infections. So what they sometimes do, so the child doesn't have to take antibiotics all the time, is they put a hole in the eardrum. This naturally grows out by itself. It'll fall out after a few months.
Okay, a quick question.
Yes.
My son has tubes, so I was wondering when it falls out, am I going to find this, or is it like?
You might.
Yeah.
You might.
That'd be trippy.
Yeah.
Okay.
I did in my daughter's ear. She had it too. Yeah.
That's great.
Yeah. Here's another ventilation tube, but this one's here kind of grown in. But here, hopefully it will spontaneously extrude after a bit of time. Hopefully the affected child will have outgrown the condition, although in 30 to 40% of cases, a further set of tubes is often required. But this is a tube that is now beginning to fall out. Tympano sclerosis almost looks like a gross-looking grub on the guy's ear canal, but it isn't. It's just calcification of the eardrum due to repeated infections. It's just kind of a corroded area of the drum. Doesn't mean the person is unhealthy, but it's just called tympano sclerosis, or kind of scar tissue on the eardrum itself. This is a retracted eardrum, when there's a vacuum behind the ear. And now the eardrum is sucked inward. That's actually the first stage of otitis media. Later on, otitis media begins to produce that serous fluid, the clear fluid, which bulges. So first the eardrum is retracted, then clear fluid begins to bulge the drum, and then that clear fluid turns into white pus, and then we're in danger. Cholesteatoma is a type of a tumor that grows on the outside of the eardrum. It's punctured the eardrum, and it's a tumor. It's benign tumor, but it will kill you because it will rapidly fill up your middle ear space. And the top of your middle ear is 1/8 of an inch from your brain. They got to get it out. Cholesteatoma. Perforated eardrum again. Lots of interesting pictures. I would advise anyone looking at this Zoom session to look at these pictures. Here's a pinhole perforation. This one will heal by itself. No need for any wow. That's a completely blown away eardrum. Okay? Subtotal perforation for obvious reasons. Oh my God. So that guy will have a big hearing loss, and he needs completely surgical reconstruction. Here's early cholesteatoma again. Remember I showed you that one over here, cholesteatoma? Here. Okay. Here's an earlier stage of cholesteatoma. Sometimes it gets trapped inside the middle ear. Anyway, we have gone about 5 or 6 minutes over our time, but you get the general picture here. Oh, here's the last picture. How long was it? Just one picture short. Look at this. Okay, advanced congenital middle ear cholesteatoma. Again, the tumor growing just inside the eardrum. The whole eardrum, you can't see a cone of light. You can't see that manubrium of the malleus. Everything is just like, whoa. See, you're going to often be the first person who sees stuff like this. And you're going to be the one who's going to have to make a proper referral to a doctor. So that's why we spend some time looking at really making sure that we understand some of the stuff about the ear. Now, what I want to do is get to our notes just so I can share screen here, and I want to, but I keep getting this silly business here. There, good. I'm going to shut that guy down. So, osteoma, a bony spur, benign tumor of the ear canal, swimmer's ear, atresia, remember, complete closure, often found with what's called Treacher-Collins syndrome. Children whose eyes are a little too close together and their ears are not totally formed. It's a congenital condition, a genetic thing. That's total, complete closure, but the most common is stenosis, a partial closure, usually due to excessive wax, can also be caused by an osteoma, or even things like kids putting into their own ears pieces of toys, God knows what, or even cockroaches. So there we have it. Basically, stop share. We're done the outer ear, Unit 2. Next week, we'll begin the middle ear. We're going to spend 2 weeks on the middle ear, because as we move from outer to middle to inner, things get more and more complicated. 1 week on the outer ear, we've done 2 weeks on the middle ear, and then we're going to spend a month, 4 weeks on the inner ear, because that's the cause of most hearing loss. Most hearing loss is not caused by wax. Most hearing loss is not caused by middle ear infections, tubes. That's kids. Only 5% of hearing loss is caused by otitis media or middle ear infections. 95% of hearing loss is caused by damage to the inner ear. Elderly hearing loss, presbycusis. Presbyterian, presbycusis. 95% of hearing loss by inner ear hair cell damage. Anyway, it's been a slice. This has been the 3rd Zoom session I've done for OTC today, and it is the last. I can take my voice out and go, set it on the stove here. Any questions, though? Do you have any other questions, Nicole?
Okay, I was just jotting down notes. You said X and O was labeled for what?
Say that again.
X's and O's?
X's, oh, I'm sorry. Yeah, the X's on a hearing test are the left ear. The O's on a hearing test are the right ear. Okay. And we plot them on the audiogram because we're testing how loud we need to make the tones for you to just barely hear them. And so you'll see where the X's are and you'll see where the O's are, and that indicates hearing sensitivity for the left and right ear, respectively.
Nice. Okay, and the last was, I guess it was the Latin terms for like outer. I don't remember what it was.
External, okay.
External.
Yeah. So otitis externa, oto ear, itis inflammation, externa, outer.
Okay.
Otitis media, middle ear infection, like your son had.
Yeah.
Okay, that's otitis media. That, by the way, is the most common middle ear infection.
Yeah, that's what his doctor was telling me.
It's very common. Very, 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 very common. Most kids have it. Only a third of kids don't get it. So, all right. Yeah, I had it as a kid, but I never had tubes. Anyway, live long and prosper. See you when we look at you, okay?
All right.
Bye-bye.